Yeah, so this topic which has been allotted to me is actually a very common thing that we see in our OPD. But we actually don't, when we look at literature, we don't have much literature on belching and hiccups. But I'll try to summarize whatever, scientific knowledge about belching and hiccup is available. First of all, I bring greetings from Bhavnagar to you. Uh, the when we talk of gas in intestine, so when a patient says that he has gas in intestine, so he is either referring to belching or burping, or he is referring to a bloating, or he is referring to a flatulence. So normally the amount of gas in the intestine is around 50 to 100 ml, 50 to 200 ml, and that can manifest in these ways. So when I talk about belching, I'll be discussing about belching under these headings. So first of all, what is the definition of belching? Belching is nothing but it's an audible expulsion of gas from the stomach or esophagus. Very simple definition. So audible expulsion, that you can hear it, right? Sometimes the patient, more than the patients, the relatives are complaining. Sir, he does such a loud belch that the entire society can hear, and it causes a lot of embarrassment to all of us when we go in a social function, right? So most of the times the patient doesn't complain much, the relatives complain that he is belching very loudly. Okay, now scientifically there are two types of belching that we have. One is called the supragastric belching and other is called the gastric belching. We'll first delve into the mechanism of each type of belching. So supragastric belching is a type of belching in which the LES, the lower esophageal sphincter, remains closed. So there is a negative pressure which develops in the esophagus and it draws air from the atmosphere. And because of that, the upper esophageal sphincter relaxes and then there is air inflow in the esophagus. The air goes down right up to the esophagus and into the up to the lower esophageal sphincter. But the lower esophageal sphincter doesn't open and the air comes back and it is released with the from the upper esophageal sphincter, which gives a belch. So throughout the entire process, the lower esophageal sphincter remains closed. So this entire mechanism is happening within the esophagus. If you do an impedance study, I'm sure, I think Shreya has a talk on manometry and impedance. So impedance study is basically when we look for objects which coming out, gas or water, fluid which comes in and out of the esophagus. Impedance studies show that the entire thing is happening in the esophagus, right? So air is traveling in the esophagus, not in the stomach. If you look at gastric belching, then actually there is a presence of intragastric air and there is a transient lower esophageal relaxation, which we call TLESR. So TLESR happens and the air comes from the stomach into the esophagus and the pressure inside the esophagus increases. So the upper esophageal sphincter opens and then it comes out as a belch. That is the corresponding impedance picture of the gastric belching. We will not go in details of that. So the basic differences between supragastric belch and a gastric belch is the supragastric belch is voluntary. It is not reflex mediated. Many a times it is behavioral. It is, when you have patients sitting outside the OPD, you will be hearing that, a lot of belching is happening. When patient is coming and when he sits in front of you in the chair, then he will keep on belching till you start talking to him. Once you start talking to the patient, him or her, then the belching actually comes down. Patient often seek medical attention for this and it may be associated with GERD. Gastric belching is actually a true belching. It's a reflex. It is involuntary. It is a vagally mediated reflex. It is often physiological. So sometimes up to 20, at some point of time, we all have had a belch in our life. So it is a natural phenomenon to remove excess air from the stomach. So up to 25 to 30 times a day belch is actually normal, right? But frequent and distressing symptoms are less common. Other functional GI disorders, or as Dr. Vinit sir said, disorders of gut-brain interaction can coexist, like GERD, dyspepsia, IBS, they can coexist with gastric belching. Now, how do we clinically evaluate? First, we look at the duration of the symptoms. Generally, some transient belches are fine, but when it persists for a longer time, then the patient comes to us. So when the patient comes to us, duration is generally a significant duration. The frequency of the belch, how frequently the patient belches, exacerbating and relieving factors. This is particularly important for supragastric belching because it is related to stress, lack of sleep. If you distract the patient, then the belching might stop. If you pay more attention to the patient, the belching will increase. So these are certain exacerbating and relieving factors. There is an effect on quality of life. There is social disruption. More than anything else, there is embarrassment and there is workplace disruption. There can be other coexisting conditions for which the patient may give history, GERD, dyspepsia, IBS. There may be associated psychiatric symptoms like symptoms of anxiety, depression, obsessive compulsive disorder. There can be comorbidities. Also important is to take a history of drugs, surgery, smoking, diet, particularly if the patient has a habit of chewing a lot of gum, because that is also associated with increased gas in the intestine. Examination, you have to observe the patient, that how he belches. There are certain patients who come in your OPD, they ask you to press some hands and legs, and then they will belch. So most of these times, these patients are patients of supragastric belching. So these are voluntary and they are associated with some psychiatric problem. General abdominal examination is also important. Most of the times for belching, tests are not required because the diagnosis is clinical. For research purpose, impedance study is the gold standard, but it is not used in common practice. It is only used for either if it's a difficult diagnosis or for research purpose to find out which drugs are useful or which maneuvers are useful. Investigations only to be done if the patient has alarm symptoms. If the patient has advanced age, loss of weight, loss of appetite, GI bleed. So in these conditions, then you have to do investigations, which would include an upper GI endoscopy and an imaging of the upper GI. The Rome-4 diagnostic criteria also says that the symptoms should be bothersome, and bothersome belching from esophagus or stomach for more than 3 days a week. Criteria fulfilled for last 3 months with symptom onset of at least 6 months prior to diagnosis. Now we come to management. Before embarking on management, one has to acknowledge that these patients do affect the patient's quality of life. Explaining about the patient's condition and its benign nature is very important. That is, this is not a serious problem and it can be tackled. Most of the therapies, because supragastric belching is the most common that we get in our OPD, most therapies are aimed at behavior modification. If there is associated GERD, dyspepsia, psychiatric symptoms, it should be treated. General dietary measures which are told us to avoid chewing gum, carbonated drinks, and smoking. So when we talk about supragastric belching, there are 4 things which are important in treatment. So one is speech therapy, second is diaphragmatic breathing, third is cognitive behavioral therapy, and fourth is, in a very minority of patients, you need to use PPIs where you have symptoms of GERD or dyspepsia. Okay, so speech therapy and cognitive behavioral therapy is something which we can't give. Actually, it requires a therapist. But what we can do is to teach the patient the process of diaphragmatic breathing. I'll come to it. So these are the evidences for all the treatments which are there. I'm not going in detail. So diaphragmatic breathing, how to do? So this is a short video on how to explain to the patient diaphragmatic breathing. It can be done in supine or sitting position with one hand over the chest and one hand over the abdomen, above the navel. Now patient is then asked to inhale through the nose and exhale with the mouth open. And in this process, he should move only the abdomen. The chest and the neck should not move. And this should be a slow inhalation and exhalation. And you have to explain to the patient that this is like inflating and deflating a balloon from the stomach, from the abdomen, right? So like that, he's explained, and goal is that the abdomen to rise and the chest and neck and shoulders to remain still. And it is recommended to perform for 5 minutes thrice daily. Okay. And this can be done initially in supine position, and then when the patient is comfortable, it can be done in sitting or standing position also. So this is what we can intervene in such patients. CBT and speech therapy is something that requires a proper therapist. And in in the city that I live, though you will have to refer to another city to get a therapist, right? Speech therapy involves explaining the patient. Speech therapy actually involves explaining the patient about his condition and then treating it. So management of gastric belch, this was all about supragastric belching. Isolated gastric belching is rare. Generally, it is associated with diseases. So that, gets treated with treatment of the underlying condition. Same dietary measures. Diaphragmatic breathing is useful in gastric belching as well. Baclofen is found to be useful, and there are certain surface tension reducing agents like simethicone, which are useful in gastric belching. Two conditions where patients actually have difficulty in belching is that you have to recognize. One is achalasia cardia, and second is patients who undergone fundoplication where the wrap is very tight. So in these patients, actually, it's not related to the talk, but it's a clinical point. Since it's a PG lecture, you should know. So now we come to the second topic, is hiccup. So what is hiccup? So hiccup is actually an involuntary spasmodic contraction of the diaphragm leading to sudden inspiration followed by an abrupt closure of the glottis. And the abrupt closure of the glottis is what causes the hic sound. Now, occasional hiccup is very common and it is self-limiting. We all have experienced hiccup sometime or the other. If the symptoms persist for more than 48 hours, then it requires evaluation. Incidence is unknown, but it is more common in men. The hiccup reflex, hiccup is actually a reflex, and there is a hiccup center in the brainstem, and the neurotransmitters GABA, dopamine, and serotonin are supposed to be modulating the hiccup reflex. The afferent pathway is the phrenic, vagus, and the sympathetic nerves. So do you know that these have innervations up to the kidney, urinary bladder, and lungs, stomach, liver, everywhere. So ENT, everywhere you have vagus nerve and the phrenic nerve and the sympathetic nerves. So the causes of hiccup can be varying. And the motor pathways to the motor fiber of the diaphragm, intercostal muscles, and the one which supplies the glottis is the recurrent laryngeal nerve. So because I told you that the innervation of the vagus and sympathetic and phrenic nerve is so vast, then the causes of hiccup is also varying. Central nervous system causes vascular, infectious, structural causes. Peripheral nervous system, there are GI causes. So even a simple endoscopy, when we do an endoscopy, if we inflate the stomach too much, then the patient ends up with hiccup, So then thoracic causes, cardiovascular, pulmonary, ENT causes like herpes, otitis media, pharyngitis, foreign body in nose and ear. Toxic metabolic causes, most common causes alcohol. Too much alcohol intake can lead to hiccups. Then what we find in hospital is hyponatremia, hypokalemia, renal impairment, diabetes. These are other common causes that we find in hospital. So some drugs like steroids, dopamine agonists, chemotherapy, particularly carboplatin, they can lead, barbiturates, opioids can lead to this. Psychosomatic events can lead to this thing. Upper GI causes, in 184 patients with persistent hiccups, the amount of upper GI causes were found in 48, and most of them had complete response. So clinical evaluation, you find the duration of symptoms, symptoms related to organ systems, find the history of drug intake, psychiatric symptoms, look at other organ systems, CNS, pulmonary, GI, cardiac, ENT symptoms, right? Investigations required So first is a blood electrolytes, creatinine, LFT screen, ECG, chest X-rays. If there are localized symptoms, then target the organ systems. If there is GI cause, upper GI endoscopy, abdominal imaging, and sometimes a pH study would help. If there are no localizing signs, brain, thorax, abdominal imaging, upper GI endoscopy would help. So management is quite simple. Treat the underlying cause, non-pharmacological, pharmacological, and invasive maneuvers. If the non-pharmacological maneuvers, all this all what our dadima says, sometimes bite a lemon, swallow sugar, cold water gargle, rapid water swallowing, vagal stimulation, Valsalva maneuver, carotid massage, sudden fright, interrupting the respiratory cycle, breath holding, that may be useful. Certain drugs, baclofen, GABA agonist is useful, metoclopramide is useful, gabapentin is useful. PPIs are useful in a minority where GERD is associated. There are certain good drugs like chlorpromazine and prochlorperazine, but because of their extrapyramidal side effects, they are not used very commonly now. There are some invasive procedures where you don't get any treatment for hiccup, where you can use acupuncture, implanted vagus stimulator, or a phrenic nerve block. But however, it's not done very frequently. Acupuncture, mainly the data is from Chinese studies, not replicated anywhere else in the world. So this is the last slide. History, if localizing features, then evaluate that system. If no localizing, CT, chest, abdomen, head, gastroscopy, treat the underlying cause, and the other therapy is non-pharmacological and pharmacotherapy. I'll just end with this story of Charles Osborne. He was born in 1922 at the age of, he was born in, at the age of 29 in 1922, he fell down, and while weighing a pig, started having hiccups around 20 per minute. He had hiccups for more than 400 million times during his lifetime. His name is there in the Guinness Book of World Records. Held a variety of jobs, married twice, had 8 children, suppressed the noise by breathing between hiccups. His hiccups, curiously, his hiccups stopped at the age of 96, and he died after 1 year at the age of 97 in 1991. Thank you very much for your kind attention. Questions, if any?